Thank you. I have no disclosures. I'd like to thank ICS for the opportunity to present our research. Fecal incontinence has a major impact on the quality of life of those affected. Up to 25% of community-dwelling women suffer from FI, and this number is higher in the older population. 3 main phenotypes have been described in the literature, and this includes urge, passive, and combined FI. A paucity of data exists comparing outcomes of treatments of these phenotypes. The primary aim of this study is to characterize symptom-specific distress and impact on quality of life among women with urge, passive, and combined FI phenotypes. The secondary aim is to characterize FI symptom distress and impact on quality of life in women with a potential 4th phenotype, stress FI. This study included women presenting to a single academic center for evaluation of fecal incontinence between 2003 and 2017. All patients filled out the Modified Manchester Health Questionnaire, which is a validated survey containing the Manchester Health Questionnaire measuring symptom impact, as well as the Fecal Incontinence Severity Index measuring symptom-specific distress. General health-related quality of life measures was assessed using the short form 12 questionnaire, and patients were divided into 4 phenotypes based on their answers to the symptom-specific questions in the MMHQ. Demographic data and medical history were collected. Anorectal manometry and endoanal ultrasounds were performed to assess physiology. The appropriate statistical analyses were performed, controlling for pertinent baseline characteristic differences. In total, 404 subjects were included in this analysis. Mean age was 58, and 88% were Caucasian. Baseline demographics and medical history were similar, except for these noted below for the primary and secondary outcome. Table 1 depicts symptom distress and impact, as well as anal rectal testing results in women with urge, passive, and combined FI. Symptom-specific distress and impact on quality of life was significantly increased in combined passive and urge FI compared to urge and passive FI. There was no difference in anal rectal testing results among these 3 groups. Table 2 depicts our secondary outcome, which is symptom distress and impact, as well as anal rectal testing results in women with urge, passive, and this potential 4th phenotype, stress FI. There was no difference among these 3 groups in symptom-specific impact, but there was a difference in terms of urge FI having lower distress scores compared to the other 2 phenotypes. Anal rectal testing results were similar across all 3 groups, except for passive FI having higher rectal capacity compared to the other 2 groups. The strengths of the study include a large cohort of women presenting for the evaluation of FI. We also use validated measures in this study. This contributes to the literature on symptom distress and impact on quality of life in women with fecal incontinence. Weaknesses of the study include a not well-described definition of stress FI in the literature. It's also a small sample size of women with stress FI only in this population. This is a baseline analysis only and does not include data on outcomes of treatment in these women. In conclusion, among the 3 main subtypes studied, combined urge passive FI has a higher symptom distress and impact on quality of life than either urge or passive FI alone, despite similar anal rectal testing results. Further research is needed to determine the significance of stress FI as a potential phenotype and its response to treatment. Thank you, and I welcome your questions.
Thank you for your presentation. Jenny Kruger from New Zealand. Could you give us just a brief example of what stress FI is?
Yes. In the MMHQ, there's a question related to, do you leak solid or liquid stool with coughing or sneezing, just like just like the urinary incontinence questionnaire? Not all fecal incontinence questionnaires include that question, so I thought it was particularly interesting to look at just that subset of population.
Thank you.
Thank you so much.
Thank you.